We are recording now. Just so we know, I'm just going to pull some things together here. I talked briefly about melanocyte stimulating hormone last time. One of the hormones coming from the anterior pituitary, and I said that it actually played a role in appetite. So I just wanted to show you again. This was our slide, one slide on appetite. Pro-opiomelanocortin neuron is actually involved in appetite. So just bringing a few things together here. All right, so in addition to that, let's go to our endocrinology. Here is where we left off. We talked about growth hormone, right? Growth hormone last time, just a brief review. Here are some of the symptoms. If there are issues, the normal effects of growth hormone. These are the metabolic effects. Remember, growth hormone does the opposite of what insulin does. Okay, it actually elevates blood glucose levels, stimulates gluconeogenesis. Usually that occurs in the liver, and what that does is it produces new glucose molecules and delivers that into the blood. It does block glucose uptake. That's not what insulin does, which we'll learn about today. So it elevates glucose levels in the blood. And it promotes utilization of fatty acids as energy instead of glucose. Okay? So remember this, we're going to be talking about thyroid hormones today too. It does work synergistically with thyroid hormones. And trying to make it easy again, a good test question is that growth hormone works through IGF-1. So if you block the receptors for IGF-1, you actually block the effects of growth hormone. And then we talked about two diseases, pituitary dwarfism. This occurs when there is a lack of growth hormone secreted. And gigantism and acromegaly. This is an overproduction of growth hormone. Gigantism occurs during puberty, and acromegaly occurs after puberty. Usually this is a pituitary tumor that occurs. All right, so again, summing up, I just want to make sure that you realize what our, this is just a review to kind of give you an orientation again of what we're talking about. We're still talking about hormones coming from the anterior pituitary gland. So we've already talked about growth hormone, but we will be talking about thyroid stimulating hormone, adrenal corticotropic hormone, that's the stress response, and some of the sex hormones. Okay, so the thyroid gland, let's just jump into the thyroid stimulating gland. Just so you know, the thyroid gland, let's give an orientation here, is a butterfly-like organ that wraps around your trachea. Okay, so it's around your trachea here. I wear a lot of turtlenecks, actually. I don't know if you've noticed, but I have a good goiter, actually. So it's been tested, it's benign, but it just is, so it's kind of a lump on my throat. But that's exactly where your thyroid gland is. It has 4 kind of different lobes that wrap around your trachea. Okay, so let's dive in, just still talking about anatomy, dive into what the thyroid gland is comprised of, okay? What you see here are these follicle cells. These are epithelial cells that line a cavity called the follicle cavity or colloid. So this word right here at the bottom of the slide, colloid, is the same as the follicle cavities. That's the space that is lined. It's basically the boundary of this space is these follicle cells. They're epithelial cells. Okay, in between here too, you see these C cells. Aside from the function of thyroid and the production of thyroid hormones, C cells produce calcitonin, a different hormone that controls calcium levels in the blood. So this is one of the last slides you'll see today. C cells, just giving you some orientation here. Okay, so diving into these follicle cavities, here's the thyroid follicles. Now, this is a little bit confusing, so I want to take some time to give you some orientation. This box right here really doesn't represent this huge slide very well, because you can see at the top of this box is the follicle cavity, but it's the bottom part of this diagram that's actually the follicle cavity. So think about this box, but then flip it upside down. So this is the interior of the colloid or the follicle cavity, and then on the other side is the blood supply. Okay? If you have any questions or confused about this, just come on up after class and I can re-explain it to you. Okay, so basically what's happening, let me give you a sequence of events on how thyroid hormones are produced. The first thing that happens is the follicular cell synthesizes enzymes and a molecule called thyroglobulin. And that's what this string with these branches represents, thyroglobulin. The other thing is iodine is actually transported into the cells, these follicle cells, across the basolateral membrane, right? It's coming in from the blood by this secondary active transporter that's using the sodium gradient to move iodine into the cell. Okay? And it's transported across the apical membrane by a facilitated diffusion transporter. Okay, so iodine is very necessary in this process. Okay? All right. Thyroglobulin and iodine, they are promoted to react with each other to make what's called T3 and T4. T3 is triiodothreonine, and T4 is a molecule called thyroxine. And you'll see this in the next slide. So enzymes add iodine to thyroglobulin to make T3 and T4, and on your exam you don't have to remember thyroxine or triiodothreonine. It'll say triiodothreonine in parentheses T3. Okay, so don't memorize, just recognize it, okay? Thyroglobulin is taken back into the cell by endocytosis, and then intracellular enzymes separate the T3 and T4 from the thyroglobulin, and then they are transported into the blood. So as we'll learn in just a minute, these thyroid hormones actually increase metabolism of your cells. And the way they do this, you'll see this again, is they sensitize the cells to epinephrine. They sensitize your cells to epinephrine, increasing metabolism. Okay, this isn't biochemistry or organic or anything like that. So don't memorize these structures. Just know that these T3 and T4 are made from tyrosine. Tyrosine is an amino acid. Okay? And you have different enzymes that promote these reactions, iodinases, that ultimately make T3, triiodothreonine, and thyroxine. One more time, this thyroid hormone sensitizes your tissue to epinephrine in all of your cells practically, liver, kidneys, heart, nervous system, skeletal muscle, and it stimulates cellular respiration, oxygen consumption, and metabolic rate. And this is important as well. It works synergistically with growth hormone. And it's very important in maturation. Okay, so this next slide, I'm just going to also kind of go through this bottom part. Again, same thing. Thyroid hormones increase oxygen consumption and heat production as well. That's important in some of the pathophysiology that's associated with disease states. All right, this slide again is kind of going back to what I talked about on Monday. I want you to realize that it is Thyrotropin-Releasing Hormone. That is the hormone that's released from the hypothalamus. This is part of your hormone worksheet too, which then travels to the anterior pituitary gland and stimulates the release of thyroid stimulating hormone. Thyroid stimulating hormone travels to the thyroid gland, just as we talked about before. And it, again, through the process that I talked about today, actually releases T3 and T4. Now, what I haven't discussed, just want to make sure that you understand this too. With elevated levels of T3 and T4, it actually signals the hypothalamus to then shut off. This is a true negative feedback mechanism. A negative feedback mechanism, like many hormones in your body. The only one that I discussed that wasn't the case was oxytocin, if you remember that on Monday. Remember, that's a hormone that's involved in a positive feedback mechanism during labor. All right, so this also shows you too that negative feedback mechanism. The hypothalamus is releasing thyrotropin-releasing hormone, travels to the anterior pituitary, which promotes the secretion of thyroid-stimulating hormone, which travels to the thyroid. Now, in many cases in third world countries, if there's no iodine in your diet, there's not going to be enough T3 and T4 produced, and there won't be any inhibition of basically the thyroid tropin-releasing hormone. And what that does is goiters actually start to form. And this is a really good one. Okay. In addition, I do have iodine. We all have iodine in our diets through our salt. If you actually look at your salt package, when you're adding salt to your diet, you're actually adding iodine as well. But people over 40, especially females, actually do tend to, have lumpy, bumpy, is what my endocrinologist said, thyroid glands. So that's my case. All right, so moving on. Any questions about thyroid? Pretty good? All right, so we're going to move on and talk about the adrenal gland. We'll get into corticotropin-releasing hormone and adrenocorticotropic hormone, ACTH, in just a second. But let's start off with the adrenal gland. This is the target of those hormones. Now, you may or may not know this, the adrenal gland actually sits right on top of your kidneys. All right? And I'm sure during finals week, you guys are all coming up on finals week, your adrenal gland is probably the size of your fist, because this actually mediates the stress response. I'm kidding, I'm being facetious. But just know that your adrenal gland, which mediates that stress response, is sitting right on top of your kidney here. And it's actually a modified post-ganglionic structure. Remember when we talked about the sympathetic nervous system and we talked about those post-ganglions, right? This is a post-ganglionic structure. All right, so if you did a cross-section of the adrenal gland, you can see that it's organized in a cortex region, that's the outer region, and the medulla, adrenal medulla, which is the inner region, just like the kidney, right? All right, so you can see here with this puppy where the kidneys are in the puppy and actually where the adrenal gland sits. It does have a good blood supply, right? You can see the renal artery and renal vein and the blood supply also to the adrenal gland. All right, so the adrenal gland has different layers. I'm actually going to start with the outside first, right? Again, this is a cross-section of your adrenal gland. The outer section is called the zona glomerulosa. And this actually secretes mineralocorticoids like aldosterone. This is actually where aldosterone is coming from, the adrenal cortex region. The layer right next to the zona glomerulosa is the zona fasciculata. And this is where cortisol, or corticosterones, are coming. These are glucocorticoids, and I'm going to talk about that in just a minute, so I'll fill in the blanks here. I'm just still talking about anatomy. The next inner layer is called the Zona Reticularis, and these are where some of our sex hormones are coming, mainly androgens, testosterone, estrogen, things like that. And then the very interior of the adrenal gland is the adrenal medulla, and this is secreting catecholamines like epinephrine. Now, epinephrine is also part of that stress response. If you have a surge of epinephrine, remember that's your fight or flight. But I want to put some things together too. It also causes anxiety, tremors, nervousness if you have too much epinephrine. Okay, so let's put more of these things together. This is actually a somewhat complicated slide, so I'm going to go ahead and the next slide kind of zooms in on parts of this same slide. If you need some text associated with it, here are some balloons to help you interpret it. But let's go ahead and zoom in on the top part. Okay, so when we're talking about ACTH in particular, again, this is adrenocorticotropic hormone. I want you to immediately think that this is part of the stress response. So this is the hypophyseal adrenal axis. Now, what's happening here is the hypothalamus is secreting corticotropin-releasing hormone. This is something that we talked about briefly on Monday. It travels to the anterior pituitary to secrete adrenocorticotropic hormone. And don't worry on your exam too. Remember, it'll say adrenocorticotropic hormone and then parentheses ACTH. So you just need to recognize the name. And it's the Zona Fasciculata that is secreting these glucocorticoids like cortisol, corticosterones, cortisone. All right. CRH is released by the hypothalamus, triggers the anterior pituitary to release ACTH, which travels to the adrenal gland to release cortisol. So what exactly does it do? Here's the key, and this is something that you will need to study, all right? It also has opposing effects of insulin, all right? What it does is it elevates blood glucose levels, just like growth hormone. It promotes gluconeogenesis in the liver, which means it's producing new glucose molecules and delivering it into the blood. And it's promoting fat and protein catabolism. And you'll see how that kind of fits in just a minute. So it's promoting the breakdown of protein and fat instead of the utilization of glucose. So individuals that have Cushing's disease, I'll just put it together here, that is an overproduction of cortisol. Usually tend to have muscle wasting, right? And they lose maybe a lot of fat. Fat catabolism occurs. The other thing that happens, and I'm sure you all notice this, when you're super stressed out, it basically, cortisol suppresses your immune function and you tend to get sicker more often, right? So it diminishes the function of your immune system, which is why cortisol helps, right? When you get cortisone shots, it's actually depressing your immune function and helping with inflammation as well. Okay, so that's a good way to remember it. All right, so let's talk about the adrenal gland in a little different capacity too. Remember, the adrenal gland is also secreting epinephrine. Catecholamines are another term for epinephrine. It's the general term describing epinephrine. Epinephrine is a specific molecule. All right, So epinephrine is coming from the adrenal medulla, the middle, the center of the adrenal gland. And basically what it does is it stimulates glycolysis and lipolysis. So glycolysis is the breakdown of glycogen. I'm sorry, that's glycogenolysis. Glycogenolysis is actually producing glucose 1-phosphate and promoting glycolysis, right? That's using glucose that we've talked about before, especially in muscle that produces lactic acid. And lipolysis, the breakdown of fats. Increases metabolism. Let's just put that all together as well. It's your fight or flight response. And as you know already from the cardiac section, it increases heart rate and stroke volume. Now, during the stress response, you're getting ACTH production and epinephrine, which again can cause anxiety, tremors, nervousness. All part of that stress response. And then here, the only thing that I really, this is more of a review slide as well, but I do want to focus on this particular structure that's in the brainstem here, right near the pons area. The locus ceruleus. Locus ceruleus is a nucleus of adrenergic neurons, that's epinephrine, norepinephrine, that are important in maintaining attention and responding to novel stimuli. So again, heads up, good test question. Okay, here's how I'll help you remember this. Locus ceruleus. When you're super stressed, like something really happens, like I'm just going to say like you get in a minor car accident, right? This is triggered. This is actually activated, stimulated. Have you ever noticed that when something like that happens, you commit it to memory right away? Your attention is elevated, your memory is elevated, right? And you remember it for the rest of your life, right? That's how you can remember the locus ceruleus. It really increases your attention and it helps you commit these events to memory. Some people feel like they study better when they're stressed, right? Like when they have a deadline, that's when they really commit things to memory. So I'm kind of that way, actually. All right, so here's what we're talking about again. Review slide. CRH is coming from the hypothalamus, travels to the anterior pituitary, which releases ACTH. Adrenal gland releases cortisol, suppresses the immune system. There's a negative feedback, right? This is another negative feedback mechanism to shut off CRH when cortisol is high. And remember, the locus ceruleus is actually stimulated. Just another slide here. I do want to mention that ACTH is also involved in diurnal rhythms, part of the biological clock. Right? Some animals like mice, cortisol is elevated during morning hours. That's why they're most active during the morning hours. Okay? And another thing I want to mention, you can see this in this particular name, cortisol, corticosterone. These are a steroid hormone. And as we've mentioned before, binds to their receptors in the cytosol because these steroid hormones can easily cross the plasma membrane, and usually the receptors are in the interior of the cell. And then again, this is more of the same. It promotes protein catabolism, so there's a net loss of amino acids. It promotes lipolysis, so it breaks down fats to fatty acids. And it promotes gluconeogenesis, so it elevates blood levels. So, diseases of the adrenal gland actually include Cushing's disease. This is an increase in cortisol, too much cortisol, in the body. And as you can imagine, they have muscle wasting. There is actually fat breakdown, lipolysis. In horses, it also promotes a long, shaggy hair appearance. Even in humans, there's a pot-bellied kind of appearance. The trunk and the belly, the abdomen actually kind of expands. Laminitis is an inflammation of the hooves. And to treat these horses, it inhibits the production of ACTH by giving a dopamine agonist. So in this case, this is the horse before. This horse, again, has Cushing's disease, too much cortisol. And then after treatment, it looks like a normal horse. Yeah, it's pretty amazing, actually. In humans, it can actually be caused by given cortisol or cortisone over a long period of time. This was an old E.T., Entertainment Tonight reporter. He actually developed polycystic kidney disease and was given anti-rejection kind of medication, cortisol, steroids to help alleviate some of the symptoms. And over time, it also causes a rounded of the face and something called a buffalo hump. It's actually like a fat deposits in between the shoulder blades. Rounded face, fat deposits between the shoulder blades. Hyperglycemia. Remember, it elevates glucose levels in the blood. All right, so I'm not going to spend too much time on aldosterone. You all know what aldosterone does. This is also coming from the adrenal gland. It is a steroid hormone that actually travels to the kidney. It actually enters into the epithelial cells in the distal tubule and collecting duct. And it promotes the synthesis of those ENaC channels to promote salt reabsorption, and if vasopressin is on board, water reabsorption. So in essence, it increases the osmolarity of the blood. Two diseases associated with aldosterone are Addison's disease. This is a lack of aldosterone production. And surprisingly, I've had a couple of students that have been diagnosed with Addison's disease over the years. Usually the signs are a weak pulse and slow heart rate, dehydration. See this puppy here has Addison's. Depression, loss of appetite, and a lot of times, especially in animals, you'll notice an increased occurrence of vomiting. And usually what happens is dogs and people are given a bolus, a medication of aldosterone to help alleviate their symptoms. Now, Conn's disease is, and this is something I added to your slide, so go ahead and write this down. Conn's disease is an overproduction of aldosterone. So what you do is you actually reabsorb more salts, and you can imagine it actually causes high blood pressure, right? Because water's going to follow that salt movement, and it's going to cause high blood pressure, Conn's disease. All right, so a couple more diseases here. Essentially, what I want to go through is, and for nutrition students, this is actually something that I'm sure is of interest to you. This is the regulation of blood glucose levels. Blood glucose is actually tightly controlled within the blood. If it's too low, the brain can't function properly, and that can cause hypoglycemia or glycemic shock. If it's too high, it can actually cause issues with circulation, blindness. Some people don't realize that diabetes is actually one of the leading causes of blindness. And basically, osmotic balance of the blood is disturbed. So the two hormones that I need you to know is insulin and glucagon. They have antagonistic pairing. So with insulin, you basically get an increase of glucose uptake. into the cells, which lowers plasma glucose levels. And glucagon does the exact opposite. It basically decreases glucose uptake and increases plasma glucose levels. All right, so here's another kind of slide putting this all together. These are all within the pancreas. So it's the alpha cells that produce glucagon, which force cells to release glucose, elevating blood glucose levels. And it's the beta islet cells in the pancreas that release insulin. And that forces cells to absorb and utilize glucose. And as I've mentioned before, putting it all together, the delta cells of the pancreas, delta islet cells, release somatostatin. And just like I've talked about before, somatostatin inhibits everything. It inhibits both insulin and glucagon release. So what happens after you eat a meal? Okay, so let's start before you eat a meal. A lot of times before you eat a meal, you start to become hypoglycemic. On the y-axis, this is milligrams of glucose per 100 mils of blood. It's the amount of glucose, the concentration of glucose in your blood. And when you're super hungry, you start to become hypoglycemic, which actually stimulates appetite, and then you eat a meal. All of a sudden, right after the meal, you basically start to elevate glucose levels. Insulin is released. A lot of times those glucose levels exceed the normal range, and insulin promotes the uptake of glucose, which then starts to cause a decrease in blood glucose levels. And if it falls below the normal range, then glucagon will actually be released to try to bring it back into normal range. And what happens with diabetics is they don't either they can't produce insulin, that's diabetes type 1, or they're not sensitive to insulin. They're producing enough insulin, they're just not sensitive to it. And basically that is diabetes type 2. And that's what this is. This is a slide. Type 1 is also called juvenile diabetes, and that is usually caused by an autoimmune disease and diagnosed around 6 years old, when basically your antibodies with these type 1 patients, antibodies attack the beta islet cells of the pancreas and renders the patient unable to make insulin. And the treatment is diet and insulin injection. Type 2 is a lot of times due to inactivity, a lack of exercise. When you exercise, just so you know, you actually increase the number of GLUT4 transporters, especially in skeletal muscle, that allows you to respond to insulin better and uptake more sugar into those cells. If the opposite occurs and you're very inactive, the couch potato, right, you don't respond the same way to insulin. You can't take up as much sugar because you're not inserting the same amount of GLUT4 transporters in skeletal muscle. So type 2 is insulin resistance or insensitivity. It's a loss of response in the target cells. Insulin levels may be normal or high. And again, diet and exercise is the key. Although some people do take insulin to really help alleviate these symptoms, even if they do have type 2. You can see how that may not be as effective. Now, some of the symptoms of diabetes mellitus. Oh, yes. Okay, I'm going to go through this slide. Some of the symptoms is hyperglycemia, high blood glucose levels. Glycosuria, that means you have glucose in your urine. Polyuria or dipsia, that means you basically have a lot of urine production. And polydipsia So it kind of acts as a diuretic, kind of disrupting those osmotic forces within the kidney. And polydipsia is being thirsty all the time. Okay? And that's because you're not able to concentrate urine. Polyphagia is overeating, actually. Overeating. And why do you overeat? It's because your cells are starving. Yeah, you're not getting glucose in those cells. And the treatment for cats and dogs is basically excessive urination, insulin injections. Now, I didn't get to parathyroid hormone and calcitonin. I will record this lecture. Actually, there's one already online if you want to take a look at it from last spring. But I'll go ahead and record these last 2 slides. It's actually 4 slides, and I'll put this online. Megna's actually going to pass out the SRTs. I want to thank everybody. I can't believe it's over already. I want to thank everybody for a wonderful semester. I really enjoyed all of you. Yeah, sad. I'm going to cry. Okay, so if you have any questions, come to my office. I'll be there all day. Remember, the review session is Friday. I really had fun, y'all, and if you have any questions, please do. All right, good luck with your finals. Thank you, yay. So fun, so fun. All right. I'll be outside, too, if any last-minute questions. Thank you, Megna, for passing that out, and I'll be outside. Let me just open this up for you now, just so we know that I get this in. Oh, my gosh. I almost forgot to stop this.
1 second.
Hold on.
You're good.